Alright students, we're going to go on to Chapter 10, Substance Use Disorders, and we're going to finish up with Segment 6, talking about treatments. In 2014, about 14 million people over the age of 12 received treatment for alcohol abuse or dependence. Yet, over 17 million people over the age of 12 were in need of treatment, but they didn't get it. Only about 24%, about a quarter of people who are physiologically dependent ever end up getting treatment. There is a huge need for those of you that are interested in doing clinical work. There is a huge need for counselors and psychologists and clinicians to work in the area of drug and alcohol treatment. Generally, when we approach treatment for those that are addicted to alcohol, those that have an alcohol use disorder, it's basically a two-part treatment. The first part is usually an inpatient hospital treatment where that individual is going to go through detox or detoxification. This is the withdrawal from alcohol under medical supervision. I always believe that this is best practice when it comes to the first step of getting off of alcohol dependence. You do want someone who has been a heavy drinker, particularly someone who's done this for a long period of time, to do this with medical supervision. And it may be necessary for them to be able to detox properly. The second step of the treatment for alcohol use disorder usually involves Alcoholics Anonymous, or AA. AA is one of the largest self-help groups for problem drinkers. Its effectiveness has been questioned. Some research has indicated that AA participation predicts better outcomes. Other studies suggest that AA is no more effective than other forms of therapy. What's very positive about AA is that they provide regular meetings with support, understanding, acceptance, and it does promote complete abstinence. Alcoholics Anonymous understands that often with individuals who are problem drinkers, they self-select out peers. As the research that I talked about in the previous section, they will self-select peers who are also problem drinkers. And what AA does is it creates a peer group of non-drinkers. It creates access to individuals who have gone through similar experiences and gives that individual access to those peer groups so that they do not return back to old peer groups and old habits and start drinking again. One of the other positives of Alcoholics Anonymous is that it firmly believes in connecting an individual with a sponsor, and that sponsor is there for that individual in a near limitless capacity, where an individual is not going to have access that way to a psychologist or to a counselor. You cannot call up your counselor 24 hours a day, 7 days a week, just to tell them when you're having a rough time. You have to save it for your next session. But your sponsor, your AA sponsor, will take that call, will field that call, and will talk to you. So these are some of the steps to AA. It is a 12-step program. You do go through them step by step. There are criticisms of AA, and some of the criticisms levied against AA do focus in on this idea being powerless, that there is a power greater than yourself, that there is a focus on God. And some find that to be very limiting and are critical of the focus on a higher power. Other treatment approaches include couples therapy. We do find couples therapy to be more impactful than individual treatment alone. Generally, when we think about alcoholics, we really do need to involve their spouse or their parents and other members of the family in order to get everyone on the same page that this person needs to stop drinking. Cognitive behavioral therapy, this is looking at changing the ways the person thinks, the ways that that person behaves. Contingency management therapy does teach strategies to avoid places and uncomfortable situations that can trigger or are associated with drinking. And relapse prevention, again, teaching that individual strategies to keep from relapsing. Are there any other models that we use for treatment? There is some movement towards this idea of controlled drinking. Controlled drinking is basically this belief that people who are problem drinkers can consume alcohol in moderation. The idea here is that you don't go into total abstinence and you don't go into inebriation. What you're doing is called guided self-change. In other words, you are changing your relationship to alcohol. You are changing your behaviors around alcohol. You are not going to drink excessively, and you're not going to completely stop drinking. You are going to learn how to stop drinking. Again, some individuals find that this approach fits their lifestyle because it allows them to continue to participate in family events and work events without having to explain why they're not drinking, yet keeps them from drinking to the point of excess. Do we use medications? Yes. One medication is antabuse. When an individual takes antabuse and they drink, it produces nausea, it produces vomiting. The idea here is that they come to learn and make the association. This is a behavioral technique. They make the association between the alcohol and the vomiting. There are other medications. Those medications include naltrexone and naloxone, but generally speaking, medications are most effective when they're combined with cognitive behavioral therapy. So what sort of treatment paradigms do we use when we talk about nicotine dependence or nicotine use disorder? First of all, one of the things we find with people that are smokers is that their peer behavior, the peer behavior of those around them, is very important. If there are other people within their family, within their immediate family, or within their social network, if those individuals are smokers, it is very difficult for them to stop smoking. If everyone decides to quit, it increases the likelihood that that individual is also going to stop smoking. So, for example, if you have a married couple where both people are smokers, both of them need to make the decision that they are both going to quit, and they're going to stick to that. Because if one continues to smoke, it is difficult, very difficult, for the other one to make the commitment to stop smoking. It is a general practice now that physicians ask all their patients when they come in, do you smoke? If you say yes, they will advise you to quit smoking. And what's interesting is that most people by the age of 65 have quit smoking. One technique to quit smoking is called scheduled smoking, where you're reducing the nicotine gradually over a few weeks. So in other words, you're not quitting cold turkey. What this approach tells us to do is, let's say you are a pack-a-day smoker, which is 20 cigarettes. Okay, on Monday you'll smoke 18, on Wednesday you'll smoke 16, on Friday you'll smoke 14, and over the course of a few weeks you will get down to only 1 or 2 cigarettes a day until ultimately you'll say, okay, that's it, I'm not going to smoke anymore. Nicotine replacement treatments, things like gums, patches, inhalers, these are all used to reduce craving for nicotine. When we combine them with antidepressants, particularly combining the patch with antidepressants, something like Wellbutrin, we see an improved success rate. A common nicotine replacement now are the e-cigarettes. They're considered an inhaler, where the individual is slowly dialing down the nicotine, dialing it down until all they're using is the e-cigarette, and then they stop. Unfortunately, what can happen with these nicotine replacement treatments is that the individual then becomes addicted to the treatment. So they continue to use the e-cigarette even if they are dialed down to 0 or nearly 0 when it comes to the nicotine. They become addicted to the gum. They continue to chew nicotine gum even though they're not smoking anymore. And there's some questions as to the effectiveness of this. E-cigarettes, there's a lot of research questions on e-cigarettes. We haven't done any sort of longitudinal study on how e-cigarettes affect us health-wise. We do know that there are some concerns. They do deliver some heavy metals, which includes nickel, and they can irritate the bronchial system. So there are questions as to whether or not it's appropriate to go on using e-cigarettes or chewing nicotine gum in lieu of smoking cigarettes. It's certainly better, but it's not optimal when compared to using nothing at all. For the most part, most physicians, when they're advising their patients on how to quit smoking, will tell you to just do it cold turkey. And if you cannot do it cold turkey, to just try a scheduled smoking. In other words, slowly sort of weaning yourself off. But generally speaking, they will say, go ahead and just quit cold turkey, and usually within 3 to 5 days, a week at the most, the physical cravings will be gone. It's really the psychological cravings that the person has to deal with. So when we think of the treatment of drug use disorders, what are some of the approaches that we use? Detoxification is always central to treatment. So I've gone over detoxification when it comes to alcohol. Again, this is managing those withdrawal symptoms in a medical setting. This is always the first step, and this is an important first step, and it should be done under medical supervision. What happens as a second step are usually psychological treatments. Cognitive behavioral therapy is especially helpful. Contingency management, basically giving that individual vouchers that can be traded in for desirable goods. This is a behavioral technique. Motivational interviewing or enhancement therapy, and also self-help residential homes, where an individual who has struggled with drug dependence goes into a non-drug environment, generally for up to 90 days. They have a lot of group therapy there and a lot of guidance and support from former users. They have a lot of one-on-one therapy, and we find that individuals that go through detox and then transfer into these self-help residential homes have much better rates of success. What's challenging about utilizing these self-help homes or self-help institutions is that they are expensive, and insurance generally doesn't like to pay for them. So one approach that we've taken is drug replacement treatments, that you're basically treating a drug use disorder with a medication. You're replacing it with a medication. The most typical one that people have heard of is methadone. It is a synthetic narcotic that is used for heroin. It's a heroin substitute. It is used to help wean heroin users off of the drug, but part of the challenge with these synthetic narcotics is that often that individual then becomes addicted to the synthetic narcotic. A lot of research now is being done on what's called opiate antagonists, and we've had a lot of success with these, a lot of success. Naltrexone is one, and Vivitrol is another one, and I'm going to give a little plug here for Vivitrol because we've had very good success rates with this. The clinical results are just now starting to come out, the data from the clinical trials, and we are seeing that individuals who have used Vivitrol, particularly for heroin addiction, it is also used for alcohol and cocaine addiction, but particularly successful with heroin addiction. Vivitrol has been a lifesaver. What Vivitrol does is it binds to those receptors that pick up the opiates, that pick up the heroin, and when the individual takes the Vivitrol, it doesn't make them high. It just binds to the receptor, but they don't get that feeling of being high. And so what happens, it allows them to wean off of the drugs without ever feeling the high. Unfortunately, what can happen is that if that individual chooses to use heroin while they're using Vivitrol, they will probably OD. They will probably overdose. So it is imperative that they do this under medical supervision and that they do not use while taking the Vivitrol. Very high success rates we are seeing when giving the Vivitrol a year later, success rates in the 60th percentile, which is phenomenally good.